Thank you very much. Admiral, dear audience, we are going to discuss one of my favorite topics. It is how to conduct physical examination of seafarers. I will have to say in the beginning that this is from a civil point of view. I have a past period of service in the Navy, and we had a lot of medical selection there, and that is slightly different because we then want to select warriors. We want to find soldiers. We want to find people that can go to war. But in the civil context, in the civil context, we usually want to find merchant seafarers, or it could be fishermen, it could be people working on specialized vessels, but they are not selected in the same way as they would be in the military service. But this is what the civil international conventions is about. They are not military in their nature. They are civil, and they are aiming at lifting the level of merchant seafarers as far up as possible. In their nature, they will be minimum conventions, because if you want a consensus among many countries, they will never go further than to a minimum level. This has been shown earlier. The determinants for ill health at sea. There are a lot of things that compose the complete chain that ensures seafarers' health or avoid ill health. But one of this is what is mentioned in the beginning here, the PME, or the pre-employment medical examination. That is constituted by the medical standards for seafarers, and there must be quality standards for doctors and clinics, and there must be a quality assurance of doctors and clinics to be sure that the product is in compliance with the regulations. Then, of course, the working environment and living environment on board ship will have a great influence on seafarers' health. And furthermore, if an incident happens, whether that is illness or an accident, an injury, medical treatment and the level of that will be decisive. And this again has connections to medical chest, to the medical guides, to the level of skills of officers, and to the means of communication for advice from onshore. The quality of the telemedical assistance service, of course, also will be an important factor, and the availability of medical evacuation, if necessary, the quality of port health care services, and the quality of repatriation services. All these factors are influential regarding seafarers' health, but this lecture will discuss only the PME. So why do we conduct physical examination of seafarers? Well, the purpose of the standards can differ from regulation to regulation. It is not exactly the same, as I already mentioned, to select military seafarers as it is to select civil seafarers. It is also different to select people who are going to an Antarctic expedition for 3 months, or those who shall work on a ferry which is in port every hour. So this is very different, and there may be different purposes for it. Should we take care of the individual, him or herself? Should we just ensure the working capacity of the seafarer? Sorry. Are we going to avoid medical treatment on board? Is that the main point? Or is the evacuation and repatriation we want to avoid? Repatriation is very costly for the P&I clubs, and they have a very strong focus on this part of it, and they would like to avoid repatriation almost for any price. Or are we going to avoid insurance claims? Are we going to ensure safety to ship and operations? Are we going to get as many as possible to work? Or are we really selecting coming world champions? Well, the purpose of the standards will have a lot to say regarding how we do this work. The perspective of the STCW Convention is quite clear. It establishes basic requirements on training, certification and watchkeeping for seafarers on an international level. The manning levels are covered in SOLAS Convention, and then we have the Manila Amendments, which add some medical standards, mainly on vision in the A Code and physical standards in the B Code. And as you probably know, The A code is mandatory, and the B code is a recommendation. There are also specific alcohol limits in blood or breath. The Maritime Labour Convention embodies all up-to-date standards of existing international maritime labour conventions and recommendations, as well as the fundamental principles to be found in other international labour conventions. And together, these two conventions have formed the basis for the international recommendation from ILO and IMO, the guidelines on medical examination of seafarers. Are standards fit for purpose? Well, that's a very good question. There was a study done in 1997 by De Kort and Van Dijk on preventive effectiveness of pre-employment medical assessments. And they found it was quite a low accuracy regarding prevention of unwanted incidents by means of assessment of individual health, declaration of unfitness, individual precautions, adjustments of job demands, and adjustment to working environment. So why is that so, and what should we do with that? The ILO-IMO guidelines is from this second version is very much an improvement from what we had from 1997. The minimum guidelines in 1997 were at the level where Norway decided they were not good enough. We had to make our own, which were far more strict than the 1997 guidelines. And the spirit in these guidelines are the same as for the conventions. And the purpose is to safeguard the health of seafarers and promote safety at sea. There's no financial aspect of it. There's nothing to do with insurance. There is had nothing to do with military purposes. It's not soldiers we are selecting, but we are selecting merchant seafarers, and they should not become ill out at sea, because the consequences of becoming ill at sea is much worse than becoming ill with the same condition on shore. And probably first and foremost, promote the safety at sea. They should not be a danger to the ship. They should not be a danger to other crew members. They should not be a danger to the operations, and they should not be a danger to themselves. We are talking about negative and positive medical selection. And the negative selection is the most usual one in this part. The positive selection you can find more of in the military selection. So you could say regarding negative selection that we are excluding the unfit. It is frequently used, and you exclude based on disease, injury, or sequelae found. The basis is that everybody is regarded fit, and then you exclude them one by one after having found some sort of diagnostic condition which is disqualifying. And these are purely medical criteria. And you could say in a summary, everyone is fit if not proven unfit. If you move to the other way of doing it, the positive selection, that is about including the fit. It is infrequently used in civil selection, and inclusion is based on a demonstrated capability. That could be a physical one, which is the most usual, but it could also be a psychological or mental one. The basis is that everybody is regarded unfit. Then you are included people based on a demonstrated capability. It's physical and mental capability requirements, not only medical criteria. And you could say in a sum, everybody is regarded unfit until proven fit. And these are the two completely different principles of selection. The negative selection constitutes almost the complete guidelines regarding selection of merchant seafarers, while positive selection is added in the military setting. I want to say something regarding the doctor doing this work, because there are so many different roles doctors could have. If you are a general practitioner, you are working under some sort of health legislation. You are looking at the individual coming into your office as a patient, and you are there to look at this individual's best, especially if you are using a holistic approach to health and base your work on the WHO definition of what's good health. If you are working as a company doctor, it is working environment legislation that regulates your work, and the individual coming into your office is an employee. It is a worker, it is not a patient. And your actual patient is the sound working environment. You are using the employee as a measure on how the working environment works. If employees become ill because of the working environment, then you will notice this, and you will focus on how you could bring that working environment into a sound condition so that workers will be able to work and produce and not fall ill. But the worker is just a way of measuring the sound working environment. Of course, the working environment shall be sound because the worker shall not be ill, but that is in the second round. If you are an approved Seafarers doctor, you are practicing some sort of health requirements or regulations or legislation. And the individual coming into your office is just a candidate. And you are going to assess whether this candidate passes or fails. He is going to be checked in accordance or against requirements, criteria and standards. And if he passes, well, then he'll get the medical certificate. If he fails, then he will get a certificate of unfitness. So he's a candidate. It's not the patient. You're not going to treat him. It's not the worker. You are not going to use him to measure the working environment. It is a candidate for a health certificate. It starts when he comes in through the door, and it's over when he leaves your office. If you are working for an insurance company, whether that is a national one or a private one, you are assessing the individual according to rights to get some sort of payment. That could be because he has some claim after some injury or whatever it is. But if you're working for a national social insurance, then there is a specific act in Norway at least, and in many other countries, regulating this. And the individual is a client, and you are assessing his rights to financial support. And I will say, if you're working for many insurance companies, you could move even further. Most of them look upon the individual coming into your office as a counterpart. You are looking for a reason to say no to a payment. And if you can't find it, unfortunately, for the insurance company, then you have to pay. So these roles are completely different. And many doctors have several roles at the same time. They may be a general practitioner and an occupational physician working for a company, and then they also are assessing seafarers. I will say something regarding health risk and safety risk. Health risk is the individual risk or the likelihood of becoming ill or injured. But safety risk is a risk to the consequences to the safety when a person becomes ill. We do not primarily talk about health risk in the context of conducting medical examinations for the purpose of issuing medical certificate. The individual health risk in this context is equal to the likelihood for a medical incident to occur. But the safety risk you can assess only when you know the consequences on board that ship of the medical condition that occurs in the individual seafarer. Oh, it's short. Take this one. Medical certificates expires in maximum 2 years. That means that we are not looking at long-term complications. They are of less importance. Short-term incidents are important. So what does this mean? Well, if you have an individual with diabetes, you are not so afraid in the assessment of whether he or she should get a certificate, whether he will suffer from some diabetic complications in 20 or 25 or 30 years' time, because you are going to assess his working capacity and the likelihood for something to happen in 2 years' time. We are not so afraid of hyperglycemia as we are for hypoglycemia. It is the low blood sugar we are afraid of. because then they will easily and rapidly do something they shouldn't do and fail in conducting their work. But if the blood sugar is a little too high, that does usually not matter at all. So if we know the likelihood, then we can assess the risk. And an individual safety risk assessment is based on a knowledge of likelihood and the consequences in the position of the seafarer. And it is the product of these two. Well, it is extremely difficult to assess this as mathematics, and we can't use figures like that. But in the guidelines on medical examination of seafarers, we at least have agreed on what we should regard as very low, moderate or high likelihood for something to happen. In one of the courses we conducted, there was a neurologist, and I asked him, what do you, he said there was a likelihood, a low likelihood for a new epileptic fit to occur in 2 years' time. And then I said, what do you mean with low likelihood? And then he said, well, 10% per year. And then I said, well, 10% per year in my years is a high likelihood. But that's not the question, whether we agreed or disagreed. What was the point is that if we do not put figures on these terms, we do not know what we are talking about. Somebody will say low when he means 10%, others will say low when he means 2%, and we need to agree on something so that we are not talking at cross purposes. Regarding consequences, that's much more difficult. You can't put any incidence or prevalence number on them. So we have used a very, very simple matrix and call them insignificant, significant, and serious. And if you are making a product out of this, you end up in probably a very low likelihood and insignificant consequences. Well, that means it's completely acceptable. But if you have serious consequences, that could be dangerous in some times. But if the likelihood is extremely low, it is so unlikely that it's almost background incidence or prevalence as in the background population, then you could disregard it. But if it is very high likelihood, and even if there is just significant consequences, it could be unacceptable. And in the middle you have something which is acceptable if it is mitigated, and you have to consider that, of course. The extent of discretion allowed to the doctors is of importance, because that has a bearing on what you should do, how you should train them, and how you should assess them. So if you have regulations which are very strict and very clear, where it's almost just yes and no questions all the way, then you could almost use an automatic machine to carry out that medical examination, because that's just yes or no, and it is a pathway ending up in something you do not need to think about, because you will be led there, even if you are blind. On the other hand, if you let everything float, and it's up to the doctor to assess whether he or she think this is recommendable or not, then you need a high level of skills and a high level of training to ensure that decisions are the same regardless of which doctor the seafarer visits. So if no discretion is allowed, detailed requirements with clear limits for fitness, it's an easy algorithm and a pathway with yes, do this, no, do that. You need a low level of competence of the doctor, almost anyone could do it, and not much training is needed. If discretion is allowed, and the more discretion is allowed, the more this is true, then you have just upper and lower limits for fitness, and there is an area where doctors are allowed to assess themselves. It requires understanding of medical condition, of the working places, and the job demands. It needs a higher level of competence, and more training is needed. I'm going to take you through the algorithm we are using for Norwegian approved doctors, and that is because we demand an individual risk assessment of everybody, And that is because the international guidelines with the standards and criteria which we have adopted in Norway allows a lot of discretion. So on the left side you will see this blue area moving down and they will all be there. On the right side the text will change. The first step is to identify which medical incident that could occur based on the underlying condition. And these possible incidents that should be expected could be many. But if you're looking into medical studies, scientific studies, you will not find those endpoints in the studies that we want to see. Because I really want to know whether there is a risk that this seafarer will suddenly be incapacitated, whether or not that is because he cannot concentrate, if he falls asleep, or if he is tired, if he is diverted, or whatever happens, or it is a myocardial infarction, or it is syncope, or an epileptic fit, or whatever it is, that doesn't matter. But those hard endpoints you find in studies do not cover the whole field, and there is little evidence. So when you are looking at these studies, it is difficult to find hard facts. But you have to identify, if you have a person with atrial fibrillation, you are afraid of a new thrombosis, you are afraid of a more serious rhythm disturbance, and you are probably giving him an anticoagulant or antithrombotic therapy, and that means that you also are afraid of hemorrhage. If it is a patient with a bipolar disease, you would be afraid of a new hypomanic episode or a depression. And you know they doesn't come in a second, but they could come quite quickly, and they could be a higher likelihood because of the working environment which could precipitate such an episode. So when you have identified this one, you have to think that this could, what is it that could impair physical or mental function to an extent that it could threaten the ability to conduct regular work in ordinary and emergency situations. When you have identified this, you have to find the likelihood that it will happen. Then you have to go to the studies, and then it starts to be difficult, because you won't find much. I've used many days, many hours, many weeks and months to find the hard facts, and that is what we are giving to the approved doctors as a background cloth for their own assessment. So they do not get easy answer in the guidance they get from us. They get the hard facts and they have to carry out the assessment themselves. But if you are looking in different scientific papers, you should look for the natural cause and course of treatment, prognosis, complications, effectiveness of treatment, adverse effects of treatment, need for follow-up. Under these headings, you could find something that could be of use, but often you will find much less than you had hoped for. Well, after this you have got an impression on how likely it is that this incident you fear would occur, and you have to individualize it. Not all diabetics have the same frequency of an episode that could incapacitate them suddenly. Some of them are very well regulated and they haven't suffered from a low blood sugar in years, if any time. Others are having low blood sugar several times a day. So there are so many factors. Your individual knowledge about this person is necessary to individualize the likelihood, to get an understanding if he is among the worst or among the better of the group he belongs to. That could have something to do with age and sex. It could have something to do with general condition, comorbidity, stage and severity of the disease, duration of the disease, time of observation you have had, so how much you know and how much you guess, effectiveness of the treatment and follow-up needs and possibilities, etc. When this is done, you have to look at the job. Which job is expected that he should do? Is he going to be fit for many different types of work, or is it just a few, or is it just one? Which job is it? Which job tasks are there? What is the nature of the working place? Are there others having a similar job? What is the time factor when something happens? And what will happen when an incident occurs? Will he harm himself? Will he harm others? Will there be harm to ship or operation? Or will there be other consequences which you should assess? So this is the consequences. Could he fall from the ship's mast downstairs over the railing, overboard? Could he harm himself from dangerous machinery or tools? Could it be self-harm due to serious psychiatry? Is it illness that cannot be treated in due time? Or will he die? And will he harm others because of erroneous judgment and actions? Or will he just overburden them because they have to take care of him when he is impaired and cannot take care of himself? Will he harm the ship or the operation? Will there be damage to the machinery due to erroneous judgment and actions or impairment of function? Will there be operational harm due to the same? These things you must assess, and then you have a picture of what are the incidents you are afraid of, what are the consequences when it happens, and in the job. And then you can calculate the risk. Well, calculate is an exaggeration because you can't calculate it, but the principles are the same. You have a low or a high likelihood, you have insignificant or serious consequences or something excess, and you can get a picture of how serious this is or if it is not so serious. But we are not only interested in a likelihood for a medical incident to occur based on underlying disease, but we want to assess the job-related consequences that medical incident could have for the safe operation of the ship, for others on board, and the person him herself. Then there is possibility to compensate. If you are suffering from myopia, you could use glasses. That could be allowed. If you are suffering from a hearing loss, you could use hearing aids. That's not always sufficient. I'm the first one to witness that. And if you are suffering from other things, if you have got an artificial hip joint, could that be acceptable? If you need some medicines, is that acceptable? So you have to consider these different medications, these different mitigating factors. Medicines, glasses, lenses, hearing aid. Is it possible to put an extra man on work? We have had occasions where the ship owner said, well, this mate, this captain is so extremely important to us that we are prepared to put another one on board just to keep him there in case something happened to him. He could have an increased likelihood of getting a new heart event, and even then they have said, well, if we put another man on board just in case, could he then work? And we have accepted that at the appellate body on very strict conditions. Only the ship, only the shipping company, only if there is another one on board, not alone on the bridge, and such things. So there are several ways of mitigating. Compulsory specialist control, duty to inform employer, restrictions on working places and trade area, restrictions in job tasks, time limitation, and so on. Then you can evaluate your risk completely. You now had a risk without mitigation, and you know how far you could use mitigation, and you could end up and saying, well, I think it is recommendable now, if we do this and do that, then he can work or he cannot work. So if there are very clear descriptions in the regulations, you'll find it there, but now you understand how you should assess in the area of discretion you are allowed. If there is not a clear guidance, and there is not a clear guidance on many occasions in all regulations, every regulations in the whole world, I can assure you. If you have a list of conditions, that will just be a short list. I think 30, 40, 50 different conditions may be listed in most regulations, but as far as I know, there are around 30,000 identified medical conditions in this world, and you will never come in a situation where all answers can be identified and you have regulation saying yes or no to everything. That will never happen. So even with the best regulations and the strictest rules, you will come in situations where you need to do some sort of assessment. And then you have to look to the purpose of the regulations. In Norway, there is a requirement. The decision you are coming to shall be in writing. The decision shall be justified legally and medically for the seafarer, and the consequences shall be written, and how you have assessed what you have done, and your conclusion should be clear. This is because the seafarer's doctor in Norway is regarded as an extension of a governmental administrative agency, and the decision by the seafarer is a decision by that governmental agency, and it falls under this Act of Public Administration. Very few studies on relevant endpoints, very few studies in a relevant period of time, and the relevant endpoints we are looking for: sudden incapacitation, unwanted actions or behavior, overburdening of crew members, risk of evacuation and diversion, challenge of replacement, and consequences to self due to medical care limitations. These are not found in any studies, I can assure you, so there is a need for extrapolation, and the transfer value from existing studies may be little. The danger of using screening tests in medical fitness evaluation is obvious, and even if that is so, it is used extensively around the world. But if you're looking, for instance, at if you're looking at any of those tests, you need to understand the pre-test probability of the disease, and if you are assessing obviously healthy persons without any symptoms, that pre-test probability is like the background population, so it's extremely low. The sensitivity and the specificity then is of interest, and you have to interpret the results. So most prognostic studies conducted on populations with an established disease and not on a normal population without any symptoms or without identified condition. So if you are moving over to this practical example I mentioned with gallstone prevalence, which is quite low in men of 20 to 29 years age, 4.9%, and 6% of women, but at the age of 60 to 69, it's as high as 37% in men and 1.8% in women. If just 20 to 30% of people with an identified gallstone will get symptoms. That's not many. And of those who get symptoms, 70 to 80% of them will have insignificant symptoms, and most do not know that they have gallstones unless I incidentally noticed on ultrasonography. If you have no symptoms, probability of getting symptoms is 1 to 2% per year. That is very low. Minor symptoms, probability for need of treatment is 2 to 4% per year, which is low, in 10 to 15 years, then decreasing to 1 to 2% per year, which is very low. So why then exclude asymptomatic individuals with gallstones on ultrasonography? Why are some using this test to exclude healthy people? In my opinion, that is not fit for purpose. There are ethical dilemmas. Links to shipping company and manning agencies could influence the judgment of the doctor. Links to insurers could do the same. The duty to keep secret could be violated by reports completed with all medical data sent to the employer, which we think is inappropriate in our country. Fair and sound assessment could be jeopardized by these links and these violations. It should be based on best practice, but it isn't always so. The accuracy in assessment is very difficult, and the true and false, fit and unfit are there, and they sometimes are at a very high level. And there are not many newer studies after what I mentioned from the 1994 study on Van Dijk, which showed that the accuracy of PME is not very high. So, should it be an individual assessment, or is it good enough with an assembly line work? Individual risk assessment cannot be done in bits and pieces. You cannot have a doctor in the end of a long corridor with 20, 25, 30 different examiners doing bits and pieces of the examination. One measuring blood pressure, another taking the medical history, one looking at X-rays and ultrasonography, one doing this and one doing that. And in the end, there is a medical director signing 300 medical certificates a day without talking to the seafarers at all, just ticking off yes or no along the line. That is not medical assessment at all. The responsible doctor must, as a minimum, take the medical history himself, examine the seafarer personally, assess the medical reports, and make a sound risk assessment from all available information. He could use assistance to a certain extent for simple measurements, laboratory tests, ECG, X-rays, etc. You are not supposed to read this. I'll just show you that we are using a form of 6 pages where we take the approved doctor through the whole process of individual risk assessment in Norway until the conclusion. It may surprise you that there are no laboratory tests which are mandatory. All should be taken only on clinical indication, because we think that the accuracy of using a lot of such tests on healthy people is so low that it doesn't really make sense. If people are on regular medication, there is a need for a separate evaluation of that. And then the use of medicines must be assessed. Other side effects, how is the seafarer affected by these medicines? How important are they in taking away the symptoms or the condition they are given for? But it's just as important to notice what will happen if there is a sudden loss of medicines. He could have forgotten them at home. He could lose them out at sea. They could be stolen. He could run out of medicines and there is not possible to get them in the foreign port where the ship is. And then we have to see what will happen to the underlying condition when it's not treated anymore. What about Addison disease if you do not get your cortisone? What about diabetes if you don't get your insulin? What about epilepsy if you don't get your anti-epileptic drugs, and so on? Well, most of these conditions wouldn't be out at sea, but sometimes they are. If you're assessing the system for PME, you should look after the medical standards that they are fit for purpose. They should be evidence-based as far as possible, and they should be assessed by competent professionals. Quality standards for clinics must focus on the quality of the process and the product, best clinical practice and sound judgment. It should be assessed by peers who understand what they should look for in the medical records. Surveyors must be qualified, and the process of assessment should be quality assured. Results used for quality improvement, and we should establish a quality circle for improving of the standards, the processes of assessments, and so on. What about psychological assessment? Well, I have yet to see that psychometry is proven beneficial in the assessment of seafarers. I know that it is used extensively, but I haven't seen a study that can tell me that this is an accurate way of assessing seafarer and that it gives us anything. That the diversity in job and job demands make it challenging to design testing systems, and regardless of that, it is extensively used without evidence that systems are fit for purpose, and that is, in my opinion, a big ethical problem. The variables which determine the outcome of the medical selection assessment is the role of the doctor, the standards and the criteria, the purpose of the examination, the time horizon, the medical condition, the job demands, and the mitigating factors. So My conclusion would be, purpose of examination must be clear. Roles of doctors must be clear. Extent of discretion must be decided and be assessed. Doctors' training must be appropriate. Quality assurance must be in place. Individual risk assessment requires doctors' active participation in the clinical examination. And definitely the last point, studies are needed urgently. Thank you.
Thank you very much, Alf, for the very nice presentation about how to conduct the medical examination for the seafarers. So right now, it's, as we mentioned